fluid is chlorine and bicarbonate ion, and similarly the most abundant cation in intracellular fluid is potassium, and anion is phosphate and negatively charged protein or negative charged amino acid that are present inside the cell. Now, coming back to our topic, what the sodium, how this kidney maintains the balance of the sodium within the body. It is maintained within the critical or the close critical values, these critical values by this kidney. So sodium almost at every segment of the nephron. We know that what is this structure. This is the nephron, which is the basic and structural functional unit of the kidney. So this nephron have all its segments. This is the glomeruli, this is the tubular portion. So the tubular portion have its parts, proximal convoluted tubule, this is loop of Henle, distal convoluted tubule, and collecting duct. So almost everywhere in the this nephron, sodium is reabsorbed, and a positive is reabsorbed almost everywhere it. But most part of this, most fraction, that is 65% of the sodium is reabsorbed at the PCT. How this is reabsorbed at the PCT? So to understand this, we come at the micro level. How this is reabsorbed at the PCT? At the PCT, there is a co-transport, or the pump which is operating, that is called as sodium potassium co-transport. Sodium potassium co-transport. So this sodium is not directly reabsorbed from this luminal fluid into the blood. No, but there are two phases. One phase from the blood, this sodium moves from this. This is the basolateral membrane, the interstitial spaces in this basolateral membrane. From these, the sodium moves into the blood. Sodium moves into the blood, and in exchange for sodium, potassium moves within that. From the blood, potassium moves into the in this basolateral membrane spaces, and from the basolateral interstitial cell spaces, the sodium moves into the blood. So they are the Na positive K positive pump operators. Now the sodium from there, how it moves into this, from the luminal fluid into the basolateral, from the luminal fluid into the basolateral interstitial cell spaces. This is moved by the another transporter mechanism, that is called sodium hydrogen exchanger. What happens in the sodium hydrogen exchanger? The hydrogen which is liberated within these cells is exchanged for every sodium molecule. Hydrogen positive, H positive, is liberated into the luminal fluid, and sodium is reabsorbed from the renal tubule back into this. So this happens at the PCT. Now, where from this H comes? This H comes. We know that in our body there is carbon dioxide, which carbon dioxide reacts in the with the water to form the carbonic acid H2CO3, and in these cells there is an enzyme, that is carbonic anhydrase, which disintegrates or dissociates this into the H positive and bicarbonate ion. This H positive is liberated there. This H positive is liberated here. So we have certain diuretics, we have certain diuretics that are uh, carbonic anhydrase inhibitors. These diuretics inhibit the release of this H into this, so sodium reabsorption is ultimately inhibited, which leads to the net loss of the sodium with the urine. At this level, there is considerable amount of the water reabsorption also. There is considerable amount of the water reabsorption also. So the fluid is almost isotonic. Fluid in the PCT is almost isotonic. What this fluid means? The fluid which is further on going to become the urine. So we know the urine formation have the three steps. So this is the first, this is happening in the first, this is the second step, which is the reabsorption. First, that was the glomerular filtration. We will cover that in next topic. So dear, this is going in the second step. So this fluid further on after the tubular secretion, this will be the urine. So this fluid is luminal or tubular fluid. So tubular fluid is almost isotonic to isotonic to plasma in the PCT segment of the loop of Henle. So what happens to this fluid further in loop of the Henle, that is the thick ascending loop of the Henle, we will be discussing in another topic. Thank you.